Welcome to this session. We'll be looking at atypical respiratory infections in HIV. And we have Dr. Stenica. He will be able to introduce himself for today. So just a few housekeeping issues. A reminder that let's keep our mics muted through the session. And if you have any comment you'd like to make, please raise your hand, use the hand sign there, or you could put in the chat box. Feel free to and so Dr. Stenica, I don't know if you will share the slides, or we can ask IT to do that for you.
Hi, Dr. Ziambo, am I visible? Am I audible, sorry?
Yes, audible, sir.
Okay, all right, okay. Let me share my slides.
Okay, great.
I'm just having a bit of an issue with my audio. Let me just try and...
No, we can hear you.
You can hear me clearly?
Very clear.
Okay, all right, okay, that's fine. Let me share my slides then.
Okay. So network, welcome to this session, and please feel free to make your comments, questions as we go along. Yeah. So we do have our experts that either have joined or will be joining us soon. Just trying to check. We'll have Dr. Zico, we'll have Dr. Duncan, and Professor Loti Achamba. But so, Dr. Stenica, if you're ready, please, you may proceed.
Thank you, Dr. Ziambo. I'm ready on my end. I'm ready to get started. If you can give me the go ahead.
Please put into the presentation mode and
okay,
proceed.
So again, allow me to just express my gratitude to the ECHO team for affording me this wonderful opportunity to share on a topic such as this one. It's a very, very actual topic. And so we have 3 learning objectives today. The first then we also have we'll talk a bit about PCP and how to make a diagnosis and just how to go about in terms of treating the patient. So before we go further, just an outline, we'll have a brief background. We'll talk about clinical assessment and some treatment principles. And as per tradition, we have to start with a poll question. So Dr. Ziambo, this is a poll question. I think that's open to the house for them to just answer.
Thank you. So, network, we quickly want to get you involved in presentations. So, get ready and just be able to poll. Okay, so the poll question 1 says you have a patient. I don't know if these are the correct poll questions. No, this is not correct. IT, Are you able to let me know if you have the right polls?
Sorry, I think the IT team has put a wrong poll. This is poll 4. They can start with poll 1. Yeah.
Okay, there we go. Patients with advanced HIV disease and respiratory infection may not always present with respiratory symptoms. Patients with advanced HIV disease and respiratory infection may not always present with respiratory symptoms. This is a true or false. Please click on your computer if you have access to one, and then choose which one is the best answer. Okay, so we have people after polling. There's good participation. Okay, so I'll end the poll in the next 10 seconds. All right, thank you so much. So, Dr. Chitenika, you can see that most people think it's true. So let's see what you have for us. You may continue.
Okay. Yeah. So things will get clearer as we continue to present. So let's have a bit of a background to the topic. So we all know that patients with HIV are at risk of presenting with a variety of opportunistic pathogens, though we should admit that the coming of ART and antimicrobial prophylaxis has changed the picture. We don't see the same infections we'd see 10 and so on. But that being the case, still, we do have statistics that confirm that community-acquired pneumonia is an important cause of both morbidity and mortality among HIV patients. And now, just to address the title of the presentation, when we say atypical infections, what do we mean? We really mean that atypical pneumonias are pneumonias that are caused by organisms that lack cell walls. So these organisms are going to be difficult to culture and difficult to isolate. And they won't appear like normal pneumonias on this classification is really not very useful when it comes to clinical practice, especially in patients with HIV, because we can have an overlap of the two. When we come to the causes of infectious disease in the respiratory system of HIV patients, so we have 5 major groups. So we have the bacteria, which is strep, Haemophilus, staph, and the gram-negatives, interesting ones that affect HIV positive patients like nocardia and rhodococcus. Then we have, of course, the mycobacterium, which are the ones that cause tuberculosis and the NTMs. Then we have the viruses from influenza to parainfluenza and HSV and even SARS-CoV-2. And then, of course, the fungi, PCP being top of the list, which we'll have a bit of detail into. We have Aspergillus, which normally colonizes the airways of patients, but in the setting of HIV, can be treated. And then we have the endemic mycosis, which are more common in the United States. We don't see as many of them here, but you do need to know them. Histoplasmosis, coccido, and blasto. And of course, another interesting one, which is strongyloides, which can cause hyperinfection syndrome in patients that have been started on ART. So you can see that we really have a wide variety of infectious causes for respiratory disease in HIV positive patients. So how do we go about assessing them? So the first thing is that in HIV infected patients, especially advanced HIV, what has been noted is that patients may come in with non-specific features, so breathlessness, cough and fatigue, and chest symptoms are not always patient because these hosts may not have a robust enough immune system to to mount up responses like fever and so on. So when we do have an HIV positive patient that has come in for respiratory assessment, one of the most important things is to find out the compliance on ART and whether or not they're on PCP prophylaxis. Also very important things like the source of HIV infection, because we do tend to see things like KS in Africans and in men that have sex with men. And then diseases like TB and bacterial pneumonia can be more common in IV drug users, especially staff. Also very important, a travel history. Like I had mentioned, the endemic mycosis like histo, blasto, and coccido are well recognized in areas like the US. So these are some of the things that you really want to go into as you're delving into the clinical assessment. So again, when you look at the symptoms of the patient, which is what the patient will complain about, so general symptoms like fever, rigors, malaise, and anorexia are really important. Other constitutional symptoms like loss of weight, night sweats, but also just going into the specific complaints that you can ask about: cough, shortness of breath, chest pain. And just a reminder again, just to answer our first question, that especially in those with advanced HIV disease, you may not always see these showing up. When you look at the signs, again, you really want to look at the general signs. Is the patient confused? Do they have a tachycardia, hypotension? And then on inspection, you want to check if they have any signs of hypoxia like cyanosis, what's their respiratory rate, do they have any signs of respiratory distress like chest ingrowing, things like reduced chest expansion, and what are the auscultation sounds. So it's really a standard respiratory assessment. When you go into investigations, so generally with respiratory infections and HIV, the CD4 count is very helpful because it does help in narrowing the differential diagnosis. We do know that bacterial infections and TB can occur at any CD4 count, while for infections like PCP and their typical mycobacterial, they normally occur with low CD4s. When you have CD4s that are much lower, less than 50, we can even have NTMs occurring. And then also very important, if you talk to your patient and they told you they recently started ART, considering iris as well. Blood cultures are desirable because bacterial infections are common. And another thing that happens a lot in advanced HIV, apart from pulmonary TB, is TB bacteremia as well. So these should be collected. For the raised inflammatory markers, they're not really very specific, but the CD4 really helps. Sputum can help in the diagnosis of PCP and TB, especially if it's induced. However, I should mention to say that in advanced HIV disease, we don't usually see the TB being smear positive, and these patients will usually have cavities. Other things that can be sampled: stool, urine, and the lymph nodes, and even bone marrow can be sampled, especially for the NTMs, which present with pulmonary and extrapulmonary disease. Chest imaging, of course, is central in the diagnosis of respiratory infections. So we see mostly non-specific findings in patients with advanced HIV. So you can have diffuse, bilateral changes. You can have TB looking like a normal pneumonia where there's just consolidation. You can also have things like complications, for instance, pneumothorax usually can happen in PCP, pleural effusions happen in TB or in advanced Kaposi sarcoma. Then also cavities in HIV. Remember that we don't usually see TB causing cavities in HIV, but things like Pseudomonas, Rhodococcus, and Nocardia, and even PCP can cause cavitation. With pleural effusion, again, KS, parapneumonic effusions, primary lymphomas, these are some of the things that can give you chest abnormalities on chest X-ray. So this is a patient with HIV. This patient had a normal CD4. Let me just get to my pointer so that I can show you. So you can see this consolidation here. It's normally what an immunocompetent person would have. This is a patient with very low CD4. This was pulmonary TB. You can see that there are diffuse, huge nodular infiltrates across the lung. Sometimes even pulmonary Kaposi's sarcoma can give you such a picture. The IT team can run for question 2 for now.
So in this question, I hope we're learning one or two things so far. So in this poll, would like you to pick either true or false. Research has shown that PCP is one of the commonest cause of respiratory failure in patients with advanced HIV. Research has shown that PCP is one of the commonest causes of respiratory failure in patients with advanced HIV. Is it true or false?
So, Dr. Zambo, this question has a lot of implications in terms of the treatment plan for patients that show up with respiratory infections, as you'll see as we go deeper into the discussion once the poll has ended.
And I know how important this question is. Yeah. So network, we're doing fine so far. We have about 53 eligible to vote. So please poll your questions. Okay, so I'll end the poll here and share the results. So what we have here is Dr. Stanika. Most people think this is a very true statement.
Yeah, so we'll look at
so you can pick it up.
Going into the next part when we look at principles of treatment, where we'll look at some evidence for this and see whether the answers were correct or not. Okay. Okay, so when it comes to treatment principles, again, when you have a patient with a respiratory infection, more than half of respiratory infections actually we never get to know the etiology. So the first thing that you want to look at is how sick the patient is. And if the patient is very sick and in respiratory distress, especially respiratory failure, then it's very good to consider empirical treatment for PCP. It should not be delayed. If you think someone is at risk of PCP, then the treatment should not be delayed. If there's no other cause, then you might want to look at TB. And again, I will post some evidence on this just after this slide to look at what we have prevailing in Zambia and across the world. And then you can also just consider further antimicrobial treatment based on your pathogens. But the big three are broad spectrum antibiotics to cover for both typical and atypical pneumonias, covering for PCP, and of course covering for TB if you think there's evidence. Aspergillus is a pathogen that grows in most of our airways. It's non-pathogenic, but for those again with a CD4 of less than 30, if you do find some aspergillus there, then it would be considerable to just start treatment with an antifungal like voriconazole, amphotericin B. Then, of course, we shouldn't forget non-invasive ventilation. So from the evidence that we have from across the world, the commonest cause of patients with advanced HIV going into the ICU for respiratory failure is pneumocystis pneumonia. This is a retrospective study. This is a Chinese study where they looked at 10 years they looked at a history of 10 years of the patients that were in the ICU, and they identified PCP as the #1 cause of patients going into respiratory failure. This one was from the States. So from the States, they identified PCP and bacterial pneumonias as the causes of patients going into respiratory failure. This one was done by a friend of mine. You can see a few familiar names here. Zico, there's Dr. Foloshi. So this was done right here in Zambia. So this was the causes of pneumonia at UTH. When they looked at the HIV population, they found that TB was the most common cause. So that's where that rationale for saying, especially when patients are sick, covering for TB, covering for PCP, covering for bacterial pneumonia, really the evidence points to these three being at the biggest, at the forefront. So let's delve more into PCP just to get into our second objective. So PCP was previously known as pneumocystis carini. So the history behind this, is that they thought that the same type of pneumocystis that infects rats is the one that infects human beings. But after getting to know the organism a bit more, they did see to say that the type of PCP that is found in humans is not the same as in animals, and they called it Girovechi. I think Girovechi was a Polish guy that made this discovery. So it's a widespread pathogen in the environment. Most of us have latent PCP infection, though it is different from TB in that most people that get PCP infection don't get it from latent infection. They're actually via inhalation from person to person. The risk factors, so the biggest one is immunosuppression, really, if you want to look at it. So you can have HIV-related immunosuppression. It has become less common with people that are on septin prophylaxis. Nonetheless, people can still get what is known as breakthrough PCP, where they're on septin prophylaxis and they still get PCP. So then also just make sure that you find out, even if someone says that they are on septin prophylaxis, how compliant are they? Then those that are on treatment with chemo, with steroids for doses more than 30 milligrams over 2 weeks, that can cause enough immunosuppression. And then, of course, malnutrition. So again, for those that are interested in history, BCP was first identified in human beings in malnourished children. So it's not just HIV positive patients that are affected. So with PCP, there's a gradual onset. Usually the cough is dry. And then the other thing that usually pushes us to think towards PCP is that exertional breathlessness. Patients may or may not have a fever, they may be tachypnic. The chest exam, especially in the early stages, is normal. So these are some of the things, you have the patient comes in with a normal chest exam, dry cough, exertional breathlessness, and then sometimes the disease may present first time with normal thorax. There have been cases where you have pneumocystis infection in the spleen, in the liver, but these are very rare. It's mostly the comes in. Of course, we have the classic chest X-ray pattern with bilateral perihilar infiltrates, and then you can have nodular infiltrates. Um, some patients who have a normal chest X-ray, this is where CT will come into play. And that I'll pay attention to is the bilateral perihilar infiltrates. We don't, then you want to look for that bilateral ground glass appearance. One of the things, again, that pushes us towards PCP is the hypoxia, where a patient will be seated and their saturations will be normal. You can put a pulse oximeter on their hand and ask them to walk a distance. White blood count usually normal. Another thing that really pushes us towards PCP, which I've used a lot in my practice, sensitive but not specific, is a very raised LDH. So because when you look at the pathogenesis of PCP, it elicits an inflammatory response in the lungs, and primarily the type 2 pneumocytes are affected. These are the surfactant producing cells, and so you get really some damage to the alveolar lining, and lactate dehydrogenase is one of those products. So a high LDH sometimes can be used as a surrogate marker. So induced sputum has a good yield. We can have bronchoscopy with bowel, where we do some staining with either silver staining or tolidine blue. or Oramin, and these tend to help. In cases where even the bowel is negative, you can resort to a biopsy where you will see the biopsy finding is the proteinaceous exudate in the alveoli, of course. That's a typical biopsy finding. So this is what an X-ray typically with PCP would look like. So you can see these ground glass appearances. They are perihilar in both lungs. They are bilateral. Patient will probably have a CD4 of less than 200 HIV. This is a CT scan. So you can see these ground glass opacities bilaterally. Much less the same picture we see in COVID pneumonia. So this is what a CT chest would look like. The admin team can run question 3. Again, question 3 to help us answer one of our objectives.
Thank you so much, Dr. Chitanika. A lot of pearls coming out in this session, and we hope the network is picking out some important things. So the third poll is a multiple choice, only one best answer. So you make a diagnosis of PCP based on clinical suspicion and decide to start treatment with high-dose Septrin. However, the patient's caregiver tells you that last time the patient received Septrin, he got SV rash. That burned his entire skin, and he had to be in ICU. What is your best choice of therapy for this person? Give Septrin, but increase the dosage of steroids. Give IV pentamidine only. Give IV clindamycin and atovaquone. Give IV dapsone only. Very, very interesting question, Dr. Chitanika, with variable answers. So far, only half of the eligible have managed to poll. This is treatment of PCP in a patient with previous
yeah, so again,
reaction
Dr.
to
Ziambo,
Septrin.
you can see in this diagram, it's a patient that had Steven-Johnson syndrome from their first dose of Septrin. So
Exposure.
yeah, it gives people a bit of food for thought.
Yeah, it's giving me a food for thought. Okay, so we can end the poll, and so that we can quickly get the answer.
Yeah, so the answer will be
Let me just...
provided just as long as people pay attention as we go into treatment of PCP.
Okay. Have...
Oh, that was must be. I think I just need to check on the.
Okay, so end the poll. So Dr. Chitanika, we look forward to the answer in your session. Please proceed.
There's 3 things that you have to consider. So there's the antimicrobial treatment itself, where high-dose Septrin is the drug of choice. Then you have steroids for anyone with respiratory failure. This would mean anyone with if you have ABGs at your hospital, anyone with partial pressure of oxygen less than 7.5, or if you have the pulse oximeters, anyone with saturations less than 92, you should think of starting steroids. Or anyone really who has PCP and needs oxygen, then you can give them steroids. Then of course hypoxia. So patients with PCP die from hypoxia. So oxygenation can be taken to the maximum all the way up to mechanical ventilation. So in terms of antimicrobials, to answer our previous question, so there's really a lot of alternative drug regimens we have for PCP. Most of these is poor evidence to support them, but a person can be on a Tavacon alone, or it can be taken for 21 days. You can have trimethoprim plus dapsone, or you can have primaquine with clindamycin that can be taken every 8 hours. And then in severe cases, you can have pentamidine. Just pentamidine alone can work, giving a person 4 milligrams per kg once daily. You can also have primaquine that can be taken with combinations that are available and the alternative drugs. Here in Zambia, I'm trying to see from experience, I think we can have primaquine can be found because it's an anti-malarial. Then you can also have clindamycin. So if you ask me in Zambia, if I was stuck, I would probably use the clindamycin plus primaquine combination. I haven't come across dapsone. So I hope that has helped to just alleviate. But even pentamidine alone, just a single drug, I think this was one of the options in the MCQs can also work. Then just a reminder to say that we do see high rates of relapse with PCP. So you can treat someone with PCP and then the relapse is almost 60% within 1 year in patients with advanced HIV. So immediately the treatment finishes, the patient can be put on cotrimoxazole as a prophylaxis. So the last poll question, the IT team can run the last poll question just to finish up on the management. So very practical scenario here, Dr. Jambo, where I think we have seen quite a few patients, and I think this scenario is more common actually nowadays because of so many people being on ART. So it's common to see PCP as a first presentation of advanced HIV.
Okay. I've seen people have already started polling. Maybe me reading it will just disturb them. But I'll read it anyway. You have a patient that has been newly diagnosed with HIV and has presented with what you think is PCP. When would be the best time to introduce ART to this patient's therapy? Another very interesting question. Okay, network can only about 50% have board. Okay, so let me just end the poll here. So that's how the results look like. Most people think it's C, then others think it's A.
Okay. May I proceed, Dr. Jambo?
Please go ahead.
Okay. So what we have seen is that there was a bit of contention about when to start ART, but from the randomized controlled trials that have been done with retrospective analysis, the best time to start the ART is within 2 weeks. And if you do start someone on ART and then they get PCP again, then you can treat them for PCP again. But the evidence that we have is that we should not delay for longer than 2 weeks before starting someone with PCP on ART. So I hope that is clear. So just summarize, again, respiratory infections are very common in advanced HIV. And the most common causes of respiratory failure are tuberculosis, PCP, and bacterial pneumonia from the evidence that we have available. So if we have a patient with respiratory failure and advanced HIV, then we should not delay the treatment for PCP, waiting results. And then in newly diagnosed patients with PCP, these are newly diagnosed HIV patients, we can start the ART within 2 weeks. With that being said, these are the references that I used for prepare this presentation. Thank you so much, and those are my contact details for those that would love to get in touch. Please feel free to get in touch, to write. We can continue the discussion. Dr. Ziambo, let me abdicate to you. Thank you so much.
Thank you so much, Dr. Chitanika. Pneumonia is reloaded. Thank you. Dear network, I hope you've learned one or two things from this session. And we just run quickly through the pause, just for those that may have missed some of the answers as we discussed. So we'll start with the first one. We'll relaunch it. So this one, patients with advanced HIV disease and respiratory infection may not always present with respiratory symptoms. True or false? Let's see if we picked something. And so I'll give just a few seconds for people to take a guess at this. Okay, I'll end the poll. Dr. Chitanika.
Yes, so the majority are
reflections.
correct here. As we have said, patients with advanced HIV may not be able to mount a significant immune reaction sometimes to give that symptomatology. So the majority are correct. That it's true that patients may not always present with respiratory symptoms.
Thank you so much. The next poll, network, true or false? Research has shown that PCP is one of the commonest causes of respiratory failure in patients with advanced HIV. Dr. Chitanika shared some research work across the globe. What was common causing the respiratory failure in patients? Let's see if we manage to pick that. Just a few seconds, and I'll end the poll. Okay, thank you. Dr. Chitanika?
So again, the majority are correct here. It's true, and we've seen that from data that we have, PCP, bacterial pneumonia, and then of course from the data that we got from here in Zambia, we have TB. So PCP is one of the top 3 causes of respiratory failure in patients with advanced HIV. So the majority.
Thank you so much. The third poll. This one is a case. So you make a diagnosis of PCP. And this is one where you had several drugs. And you need to decide which one you're going to use. In this patient with PCP, previous exposure to Septrin led to Stevens-Johnson syndrome. So what would be the alternative as provided for during the session? Okay, so I'll end the poll and hand over to Dr. Chitenika to run us through this one.
So this one, based on the regimens that are available, the majority got it correct. So just IV pentamidine alone can be used. For the clindamycin, we said we can use it with primaquine and not atovaquone. So the majority again got this correct. To be best to acclimatize themselves with the lecture where the regimens are shown, which drugs act synergistically.
All right, thanks. And I think one other point to take note from this is it's possible to treat PCP in someone with who reacts to septrin. So let's work with our specialists and experts and consult when we are encountered with such a challenge. So the final point, Dr. Chitenka, is you have a patient that has been started newly diagnosed with HIV and is presented with what you think is PCP. When would it be best to time to introduce the antiretroviral drugs? Network, please go ahead and poll. I think this one I remember Dr. Stanek was quite clear.
No, it was clear.
Yeah, I think you can go ahead and just give your reflections.
Yeah, so from the data that we currently have available from retrospective studies, mortality and morbidity are reduced in patients with PCP when ART is started in them within 2 weeks of the treatment.
Thank you very much, Dr. Stanika. Friends and colleagues on the call, do we have any questions, any comments of points of emphasis that you'd like to make? Clarifications? Feel free, just raise your hand and then we can allow you to speak. Looks like
There's a comment
Dr.
in the chat. There's a comment in the chat. Yeah, so the answer for poll 3 was pentamidine only.
Okay. Any comments from the experts? Any additions you want to make? I've seen Dr. Peter. I don't know if you want to make a comment.
No comment from my side, but just to say that I enjoyed the presentation. Thank you very much, Dr. Stanik. Thank you.
Thank you, Dr. Peter, for joining us. Any other comments? Glad to see you, Dr. Nyaku. Okay, so if there are no comments, I would just like to say thank you. Oh, I've seen a hand. Cholemuna, go ahead. You can unmute and make a comment.
Good afternoon, everyone. My network had stripped at some point. I wanted to find out when we have a client that is presenting with these symptoms and is already for that 2 weeks. Now I wanted to find out if they are already on treatment. What are we supposed to do? I think I didn't just get that one. Thank you.
I think there was a period when your network blacked out again, so I didn't get the question in full. You said someone is already on ART treatment, then what happens?
Yes, I was asking if the client is already on treatment, then they present with those symptoms. Do we stop? Do we just add? I didn't get that clearly since I just got the first one to say when they are newly infected in newly or HIV, we have to wait for the 2 weeks. So I didn't get the other one. Thank you.
Thank you. That's a good question. So if I'm understanding you correctly, so I'm going to answer two questions. Number one, if they're already on ART and they come with PCP, you treat the PCP. You don't stop the ART. You treat the PCP as you would treat. And secondly, just for those, I think that may have this question at the back of their minds, there are patients who are on streptococcus prophylaxis that get what is known as breakthrough PCP, where despite them being on streptococcus prophylaxis, they still get PCP. So even in those patients, you just treat as you would a normal PCP patient. So we don't stop the ART. I hope that has answered your question.
Yes.
Thank you so much, Cholwe. We're happy that you participated. So I was going to say that if there are no other questions, we will end our session here and just say thank you so much to Dr. Stanika. Always a pleasure to have you on this call and always grateful for your well-researched presentations that you make on this platform and contributing to building capacity in Zambia. Any last thoughts?
I think mine again is just to express my gratitude. It's always nice to take part in this session. So it's just thanking everyone who found time to join the call, and of course for the ECHO team for granting me the opportunity to present.
Thank you so much. Always a pleasure. Thank you, IT guys, for picking this up. Malaika, thank you for joining. Our coordinators, thank you very much. We look forward to seeing you on Monday again. Have a good day.